Welcome to the latest MS Hear from the Experts webinar. These webinars help people better understand multiple sclerosis, highlights MS-related resources, plus provides tools and tips to navigate their MS journey with more knowledge and confidence. Thank you for joining us for today's broadcast. I'm Shauna McKinnon, and I'm your moderator for today's broadcast. I've had MS myself for 27 years, diagnosed in January of 1998. And I've been a volunteer with MS Society and MS Canada for almost as long as that 27 years. MS Canada would like to acknowledge that we are on the unceded and ancestral territory of First Nations, Inuit, and Métis people across Canada. These nations have cared for this land from the oceans to the mountain peaks for thousands of years and continue to do so today. We thank them for their continuous care and for the opportunity to host this session today. At MS Canada, we are committed to learning from and working with Indigenous peoples to care for the land we all call home. Before we get started with our presentation, let's briefly go over a couple of housekeeping items. Your microphones have been muted. If you do have a question, you can type it into the chat box and we'll try to get to as many questions as possible following the formal presentation. Please note that questions pertaining to specific personal situations likely cannot be answered in this type of venue. We do recommend contacting your personal MS healthcare team or perhaps contacting the MS Knowledge Network for those questions. This session is being recorded and will be available soon on our website from the Informative Videos on MS page. A Facebook Live recording will be available as well. Please note that MS Canada does not approve, endorse, or recommend any specific product, therapy, resource, or service, but instead provides information to assist individuals in making their own health and wellness decisions. Plus, the views and opinions expressed in this presentation are those of the speakers and may not necessarily reflect the views or positions of MS Canada. Since 1948, we at MS Canada have been proud to be a part of a community of people living with MS, their families, friends, plus volunteers, donors, researchers, clinicians, and many more. Together, we've helped fund research, provide information and support to people affected by MS, and we've taken a bold stance to advocate for changes that allow people living with MS to live full and inclusive lives. Our current strategic plan not only lays out the roadmap in our journey to create a world free of MS, but we hope it also provides inspiration for all in the MS community to connect and collaborate, so together we can advance treatment and care, enhance well-being, understand and halt disease progression, and prevent MS from happening. Please note that during this broadcast, a couple of pop-up polls will appear. We ask that you respond to each. The anonymous information will help MS Canada better understand your experience and the impact we are having on the MS community. Today's expert is Dr. Ruth Ann Mary, who is a professor of medicine and community health and epidemiology at Dalhousie University. She received her undergraduate degree in chemistry, her medical degree from Dalhousie University, both with distinction. She completed neurology training at McGill University, and this was followed by a fellowship in multiple sclerosis at the Cleveland Clinic, supported by a Sylvia Lowry Physician Fellowship Award from MS Canada. Subsequently, she obtained a PhD in epidemiology from Case Western Reserve University. Presently, she serves as the Vice Chair of the Scientific Steering Committee for the International Progressive MS Alliance. She is the former Chair of the Medical Advisory Committee for MS Canada, former Chair of the International Advisory Committee on Clinical Trials in MS, and a Fellow of the Canadian Academy of Health Sciences. In 2023, she was awarded the Baron-Sick Prize for Innovation in Multiple Sclerosis Research. Her research aims to understand the influence of comorbid diseases on a range of multiple sclerosis-related health outcomes. Other areas of research interests, that is, include etiologic factors for MS, patient-reported outcomes, and prodromal MS. Please welcome Dr. Mary.
Thank you so much for that kind introduction and for the opportunity to talk to everyone today about brain health. So what I'd like to do today is provide you with an outline of what we're going to talk about, and as we work through this, come up with some potential actions that you can take to improve or maintain brain health. So brain health is critically important, and so part of where we're going to start is our updated biological framework for understanding disease progression in MS, including its core components, a brain reserve, aging, comorbid health conditions and health behaviors, and how this is relevant to the brain healthy lifestyle. So in the last couple of years, there's been recognition that we needed a new way of describing or understanding the progression of multiple sclerosis as a disease when we think about the underlying pathological processes and how that manifests in the symptoms of the person with MS. And so there was an attempt to bring experts together to try and develop a framework that more clearly integrated the knowledge that we'd gained over the last few decades. And so what you see there is MS progression at the center, because that's really what we're trying to describe is how does the disease worsen and what does the person with MS look like? And so there were 4 core components that we came to. One was the importance of biological age. The second was the importance of brain reserve. The third was the injury mechanism, so the way in which MS causes damage to the brain. And the fourth is the repair pathways that exist within the brain in everybody to some degree. And on the side were a number of factors, characteristics of the individual with MS that modify all these relationships. So things like your underlying genetics, your race, your education, your diet, your activity, the treatments that you have. So we're going to talk about all of these in more detail. So what is brain reserve? Well, in its simplest terms, it's the ability to tolerate injury to the brain before you manifest any symptoms. So think of this as your hardware. So it's your underlying brain structure. So if you have a phone, this, what we're talking about, is the hardware of your phone. Is it an Android or an iOS system? So the better the brain reserve that you have, the more damage to the brain you can tolerate before you experience symptoms or somebody could find them if they were to do a detailed neurological exam. That is based on a couple of things. One of the big pieces is how large is your brain when it gets to maximum growth. So the more brain tissue you start with, the better off you are. And the second is what's the quality of the connections in the brain. That's a little bit harder for us to measure, but that's a key part of the hardware. And then there's a software component. And so this is the cognitive reserve part, and this is active. In other words, this is something that can change over your lifetime and that you can influence. So this is influenced by things like your educational level, your occupation. So what's the cognitive demand on your brain of thinking, learning new things, and on your things like your leisure activities. So that's going to be things like reading, music, learning a language. I often get asked, well, I do lots of crossword puzzles. Is that helpful? And I would say yes, but more helpful if you've been doing crosswords for 20 years because you like them is trying a different type of activity that requires your brain to learn something new and lay down new pathways. So this is an active way that we can create reserve. And so this is our software. So this helps us understand a little bit more about why we think the concept of brain health is important. So unfortunately, almost the moment that we get to that maximum brain size, we start to lose brain tissue. This is a progressive process with age. It happens to all of us. But people with multiple sclerosis lose that brain tissue more quickly. Now, you may be thinking now, since I've just told you that brain size helps protect you from manifesting new symptoms, even if you have brain injury, and that may be a problem. You're right. So as we lose the brain tissue with age, the brain reserve, that hardware, decreases, which means that we see an increase in many individuals in disability with age. So we really want to do whatever we can to try and preserve that brain health. So there are some things, and so people have shown, if we look at disease-modifying therapies, one of the things that can be done. And so use of disease-modifying therapy as early as possible in the disease course, if it's appropriate for the individual, and that's a discussion between the individual with MS and their healthcare team, being associated with better long-term outcomes. And so this is illustrated in this graph here. So the x-axis shows time, and the y-axis shows sort of worsening disability. Now, what you see here is, this is an illustration of, say, somebody got diagnosed with their MS and then started disease-modifying therapy right away. So over time, this individual has only lost this much brain tissue, and so there's a mild to moderate range of disability here. This individual was diagnosed but got disease-modifying therapy later, and so there was more tissue loss before it was slowed down by therapy, and so there's a greater level of disability. And in this individual, they had no therapy, and so the disability is greater. Now, when I say this is assuming that these are all people with exactly the same characteristics, and we know there's lots of variation in how people with MS look, and so this should not be construed to be definitive for any one person. This is trying to summarize a concept. So given the timing here, you can see that one of the key features that can help would be getting to faster diagnosis. So there's continued work on the field in terms of trying to accelerate the way in which we can make a diagnosis. And so there will be a new set of diagnostic criteria coming out, hopefully within the next few months, that gives us some additional tools to diagnose people faster. And there's also a recognition that this needs to be coupled with making it easier for people to get through the health system. A little bit harder nut to crack, but a critical point. It doesn't help you if somebody can make the diagnosis faster once they see you if you can't get to the person that you need to make the diagnosis. So when thinking about this early intervention with disease-modifying therapy, and we're not going to spend a lot of time on this because, again, this is an individual decision, it's important to recognize there are different therapies that act in different ways. Each has benefits and risks, and so it's worth reviewing this and emerging options for people with MS. It's also worth recognizing we've had fewer options for people with progressive MS to date. And so for people with secondary progressive MS in particular who don't have active disease, in other words, are not having relapses, we haven't had any approved therapies. Last spring, there was a new clinical trial of a medication called tolebrutinib in the Hercules trial, which for the first time showed benefit for delaying disability progression. That drug is now under review by the Food and Drug Administration. I don't know what the timeline is for review in Health Canada, but we're hopeful that this is the start of additional therapies that will focus more on progressive MS, since we have so many therapies available for relapsing remitting MS already. So I told you there were some other important features beyond brain reserve and what we can do about brain reserve, and one of these is aging. So onset of MS, as most of you are likely aware, is typically between the ages of 20 and 50 years, although about 5% of people will have their first symptoms before age 16, and about 0.5% will have their first symptoms at age 60 years or older. The median survival from birth for people with MS is about 76 years. So that means most people with MS will age with their disease. So it's a long time. So aging is relevant. And that's really illustrated here. So this is a graphic from a study done in the United States that I was involved with, where we tried to count the number of people with multiple sclerosis in the US. And the reason I like it is because it actually shows how many people with MS are affected per capita by age group. And it shows that our peak age group for people living with MS now in the US, and this is very similar to Canada, is people between the ages of 45 and 65 to 70. So aging really is an important part of MS care. So what happens with aging? Well, you may remember I said there were some compensatory processes in the brain. So there's natural repair, generating new brain cells, remyelination occurring. Well, the efficiency and effectiveness of those processes gets less with age. We're not entirely sure why, but that means that once damage is accrued, we're going to be less successful at dealing with it. There also develops a chronic sort of systemic low-grade inflammation, which adds to the injury which occurs. So we then need to think about the concepts of biological versus chronological age. So chronological age is what it sounds like, how old you are based on the calendar. Biological age is a slightly different concept, and it focuses how well we function biologically when we think about that relative to what you would expect for our chronological age. So it's really looking at function at the level of things like your cells and molecules, and you can have a biological age that's the same as your chronological age. You can be younger than your chronological age, or you can be older than your chronological age. And it is possible to modify that. And there are some studies that suggest that people with MS, at least some of them, are biologically older than chronologically. And it looks like there are multiple factors that influence that biological age, and some of them are illustrated here. We'll talk about a couple of them in more detail. So some of that is your genetics, some of that is your biological sex, other health conditions, which we'll talk more about in a moment, some of the lifestyle behaviors that you have, social determinants of health, as well as your environment. So things like whether you're exposed to pollution, for example. So let's talk a little bit more about some of these. So social determinants of health refer to those conditions in which we're born, grow, live, work, and play. So these have a very important impact on health, and I think underappreciated for many years, but really well recognized now. So this ranges from things like your childhood experiences. Did you have enough food to eat? Did you experience physical, emotional abuse or neglect, for instance? Those things have lasting effects on adult health. Do you have adequate housing? What's your level of education? So generally, higher levels of education are protective for your health. Do you have a social network that's supportive? Can you reach out to people to ask for advice, to get support with caring for your health? Do you have income and employment? So again, resources to help you manage your health and well-being. You live in a relatively safe, cohesive community. Do you have good access to healthcare services? There are others that we can think about, but these are all important in influencing health and have been shown in some ways to influence biological age. What about chronic disease? Well, let's step back to just the more general concept first of comorbidity. So this is a term that refers to the total burden of illness other than the specific condition you're interested in. So when I'm talking about MS, the disease I'm interested in is MS, and so all the other health conditions are going to be the comorbidities. And we can bin these broadly into conditions that happen for a short period of time limited, like infections, other time limited things like injuries, for example, and then chronic or recurrent conditions. And this is important because how we manage them is different. So if we talk briefly about the time-limited condition, so infection being an example, people with MS have an increased risk of infection, and they're more likely to use healthcare for infection. So a Canadian study showed that people with MS were nearly 2.5 times as likely to be hospitalized for infection and about 1.4 times as likely to see a physician for healthcare use, and therefore are also more likely to get medications to manage infection like antibiotics and antivirals. And this is important because it does affect health outcomes in people with MS. So a very old study, but I think still informative, was a study done by Dr. Sibley, where he showed that if you looked at a period of time 2 weeks before somebody had an infection and 5 weeks afterward, that there was an increased likelihood of relapses throughout that entire period. And in modern times, this has been seen, for instance, with influenza vaccination or with COVID infection. And so we saw a lot of that during the early pandemic. Infection can also cause pseudo-relapses. Now, this is not an ideal term because the symptoms, of course, when you have a pseudo-relapse are real and they affect function, but the pseudo is meant to help us discriminate relapses due to new inflammatory activity from MS as opposed to something else. And so these occur when there are transient stressors such as infection and are remarkably common. And again, we saw a lot of pseudo-relapses related to COVID-19 infection. So what can we do about it? Again, trying to identify factors that we can modify. Well, vaccination is something that has played a much bigger role in MS care in the last few years because infection has been a bigger concern. Because more people with MS are being treated with disease-modifying therapies that suppress their immune systems. And as you've likely heard about in the news lately with the measles outbreaks, vaccination rates are decreasing in the population. And so that really increases the likelihood you're going to bump into somebody who may expose you to a disease that could cause infection. Vaccination decreases infection risk, so common vaccines, influenza, COVID-19 vaccine, bacterial pneumonia vaccinations for strep pneumoniae, and then shingles vaccine are all potentially useful. And shingles particularly and the pneumonia and the influenza vaccines as we get older. So I wanted to share with you, although this is not as directly about MS, that sometimes we get additional benefits out of things and we're not quite sure why. This is a slightly busy slide that I borrowed from a recent publication looking at shingles vaccine and neurodegenerative disease, specifically dementia. And I thought this was relevant because there are some degenerative components to multiple sclerosis as well, which underlie disability progression. So this study took advantage of a policy change in the region where they conducted the study, where there were people who were eligible for shingles vaccine if they were born on a particular date, and people who'd been born only a week earlier were not eligible. And so that allowed them to say, well, the people born only a week apart were exposed to, similar life circumstances growing up, similar access to the health systems. It was like a natural experiment because those individuals just didn't have the opportunity to choose this therapy. And if you look at this portion of the graphic here, you'll see that the rate of getting dementia kind of changed over time and with age. These are older people and younger people. But right here, this drop in the line here is people who are different in age by 1 week, those who were unable to get the vaccine and those who were. And you'll see that there is a substantial drop in the risk of getting shingles and dementia. And so the dementia risk dropped about 20%. So there may be some additional benefits to preventing infection or using some of these vaccines that we don't yet understand. So I told you that chronic conditions are important. So what are the most common comorbid or coexisting conditions in people with MS? Well, at the time of diagnosis, they're depression and anxiety, high blood pressure, chronic lung disease, irritable bowel syndrome. And if you just take a snapshot of any given MS population at any time, you don't worry about whether it's diagnosis or 10 years in after diagnosis, most of those conditions that are most common are still the same. What we end up doing is swapping in problems with cholesterol, so lipids, instead of irritable bowel syndrome when we look later. And these conditions are important because of their impact on outcomes and brain health. So this is just meant to illustrate to you a little bit how common these conditions are in people diagnosed with MS in a study that used health claims data from 4 Canadian provinces. So those provinces were British Columbia, Manitoba, Quebec, and Nova Scotia. So almost 24,000 people with newly diagnosed MS. And as you can see here, the most common conditions are the ones that I told you about. And we're talking about for depression and high blood pressure, we're really talking about the 15 to 17% of people will have that. Slightly less for people with chronic lung disease. Now, if we continue on and we take a snapshot and we look at how things change with people's age, because I told you biological age is very important to brain health, we start to get a picture of how things change with age. And this happens in everybody when they get older. But it's just important to illustrate this because by the time you get to 60 with MS, you've probably been living with your MS for a long time. And so it's probably more complicated in terms of symptom management and other issues. So if we follow somebody with high blood pressure, those in the 20 to 44 year age range, only about that 10% of people will have high blood pressure. It's getting up to 30% as we get a little older, but it's getting to 60% by the time you're age 60. And so we see a similar pattern of rise, just not as marked, with cholesterol, diabetes, and heart disease. In contrast, depression and anxiety, which I told you were common both at diagnosis and any random point in the course of MS, those affect a similar number of people, although not always the same people, at any given age. So that's an important difference. So you may by now be wondering what are some of the risk factors for these conditions, so you can think ahead to whether there's anything that can be done to prevent them. Well, if we're looking at those psychiatric disorders like depression and anxiety, biological female sex is associated with an increased risk. That's one you can't change. Living in urban centers, being an immigrant, having a lower level of education or income, being a smoker, having adverse childhood experiences, so like experiencing physical, emotional abuse or neglect, for example, all increase your risk. And we also know that there's a genetic risk for psychiatric disorders, and if you have a higher genetic risk, that also influences your risk. And those genetic risks seem to be the same in people with and without MS. Some of those factors are the same as the risk factors for the high blood pressure, the heart disease, high cholesterol, and so on. So the lower level of income and education, the smoking, being an immigrant. But in this case, being biologically male increases your risk. Getting older also plays an important role. So we're not going to talk about this a lot because we could spend another hour here, but briefly what I'm going to say is that those comorbid or coexisting health conditions have an influence on MS throughout the course of MS. So briefly, we know that if you already have a comorbid condition when your symptoms start, it will take you longer to get diagnosed on average, that you may have more severe disability at the time of diagnosis. We're going to talk a little bit more about what the effects are on the disease course, but it does influence relapses and disability progression in some cases. Can influence how likely you are to start treatment and possibly the effectiveness of some rehabilitation treatments, and affects quality of life and lifespan. So let's just talk about a couple of these as examples. So there was a study that brought together the data from, I think, 16 clinical trial data sets. So this was work done by Dr. Amber Salter. And what she did is pull together these data sets, which had large numbers of people with MS, so exceeding 15,000 people, and identified what comorbid conditions they had at the time of enrollment in the clinical trial. So remember, in clinical trials, we're randomly assigning people to treatment groups and then following them very closely forward in time. And so what she managed to show is, first, which is not illustrated here, that the more comorbid conditions you had, the more likely you were to have a relapse. She also showed that depression was associated with a 15% increased risk of relapse. And there was also an increased risk if you had a chronic lung disease or migraine disorders. There was a suggestion, perhaps, that ischemic heart disease was associated with increased risk, but there weren't very many people who were in this category, so it's hard to be definitive about that. We also know that if you have depression or anxiety, that affects people's ability to work. So we know people suffering from those symptoms, along with symptoms such as pain and fatigue, are more likely to miss time from work. When they're at work, they're less likely to function well. So we get both absenteeism and what we call presenteeism. And then in general, life activities tend to be more impaired. Comorbidity can also influence thinking and memory, so our cognition. So we did a study in which we followed people over time, so for about 3 years. And what we showed is if people had worsening in the severity of their symptoms of depression over time, that their performance on a test called the Symbol Digit Modalities Test, which tests how quickly you can process information, worsened faster. This is a test some of you may do in clinic, or a similar version where you have to match symbols and digits. So some of you may do a similar type of test on an iPad in clinic now. So the Cleveland Clinic, where they do this, also studied over 4,000 patients, and they showed if you had 2 or more comorbidities, then you would lose more performance, so decreased by 1.46 points on this test annually. But we know that we have treatments for comorbidities. So one of the important things in preserving brain health is managing your comorbidities. So for example, in a review we did a few years ago, we pulled together all of the studies at that time that tested whether treatments for depression and anxiety were effective in people with MS. Nearly all the studies we identified for depression. And so what we found was that both medications were effective as well as psychotherapies. This ranged from cognitive behavioral therapy, where you try and change behaviors and thinking patterns, to supportive counseling. So we really grouped all of those together. The point is that those were effective, and so that's one way of managing conditions. Some more recent studies have actually shown that internet-based cognitive behavioral therapy without a therapist can also be helpful in managing mental health for people with multiple sclerosis. So by now you may also be wondering whether treating the comorbidity actually directly helps MS. And this is an important question to which we do not yet have an answer. But this study that I'm about to share with you provides an intriguing suggestion that that might be the case. So Laura Negrado did a cohort study in which she was following 50 people with relapsing remitting MS who had obesity and had some additional issues such as poor blood sugar regulation that suggested they were developing something we call metabolic syndrome. She followed these individuals with serial MRIs every 6 months. So this is shown in this figure over here. And so you can see this group of individuals had a fairly consistent level of new gadolinium-enhancing lesions at every 6-month interval. So she offered these individuals metformin, which 20 of them took. Another 20 took pioglitazone. These are both therapies for diabetes. Another group declined to have any of those therapies, and they all continued to be followed with serial MRIs. And so if you look at the red and the orange lines, what you see is after they started the treatment for diabetes, that the number of gadolinium-enhancing lesions decreased, whereas the group that did not take medication stayed about the same as they had before. Now, I should caution, this is not a controlled study. Everybody knew what they were taking. It's not at the standard of a clinical trial for therapy, but it is very interesting in terms of suggesting that we should be exploring these kinds of questions in terms of how we can improve outcomes. So I mentioned that health behaviors also play an important role. And so we know that smoking increases the risk of MS, but even after you have MS, it continues to play a role. So it increases the rate at which people accrue new lesions on their MRI. It accelerates that loss of brain tissue, so reducing that brain reserve that we were worried about. And so then you probably aren't surprised, given what I've told you already, that that's associated with a faster rate of disability progression. And there's some more recent studies that suggest it's associated with a higher rate of relapses, even if somebody is on treatment. But quitting smoking helps, and it appears that no matter when you quit, you can still get some benefit after that. So there's a study out of the UK suggesting disease progression may slow after quitting. And so if you're thinking about it, ask about the supports that are available to help people quit smoking. It can be very hard to do on your own, but we know that if you get counseling, if you consider using medications, for example, or the combination of the two, you're more likely to be successful than if you just try on your own. Now, obesity is tricky. It's perhaps not entirely fair to refer to it as a health behavior, but that's the order in which I have it in this deck because there are a lot of factors that can contribute to it. But Ellen Mowry, who's now at Johns Hopkins, showed that obesity is associated with the rate of brain volume loss. Again, that loss of brain tissue and change in reserve. So she followed a group of individuals and she classified them according to their body mass index. So your body mass index comes from a measure of your height and weight. While it's a somewhat imperfect measure, it's still been widely used by healthcare providers for a long time. So scores of less than 25 indicate people who are considered to be at a healthy weight. 25 to 30 are overweight, and 30 and above are considered to be in the obese range of differing severities. And what you'll see here is that individuals who are in the highest body mass index category lost brain tissue more rapidly. There was a subsequent study done in a pediatric population of about 453 participants with pediatric onset MS. So at the time that they were in this study, they were teens, 2/3 of them were female, and slightly over 1 in 4 of them were considered as overweight or obese. Now in the pediatric population, you should know that we don't use BMI, we use percentiles. So the 90th percentile, which is on this graph, would be normal weight, 90th to 97th would be overweight, and 98th would be obese. So what they found was at the time of diagnosis that your weight was not associated with the level of disease activity, so the number of relapses. These individuals all started on treatment with either glutathione or acetate or interferon, and that was the era in terms of what therapies were available. And the individuals who were in the overweight or obese categories had a higher relapse rate than those who were not, and they were more likely to need to switch to a more intensive therapy. We're not entirely sure why, but it's possible it just relates to the pharmacokinetics of the drug and possibly a question of whether we might need different dosing in some individuals based on weight. So what about diet? This is very important. I'm going to tell you now, I'm not a diet expert, but I think there are some things it's worth recognizing. So the Mediterranean diet is well known for its benefits for brain health in the population in general. So the Mediterranean diet limits salt, processed food, and sugar, really emphasizes fruits, vegetables, whole grains, and lean protein, and is well recognized to reduce the risk of heart attack and stroke. And is helpful also in terms of protecting people against developing dementia. There are some other small trials that generally support a healthy diet, and in people with MS, there's some trials that have looked at sort of lower fat and plant-based diets, which have been associated with improved fatigue and decreased weight, but they did not specifically look at brain health. Excuse me. Physical activity is another important health behavior, again, relevant to this question of brain health. Why is it relevant? Well, it lowers your blood sugar, so it can help with preventing and managing diabetes. It lowers blood pressure, so again, could prevent and help manage high blood pressure. Decreases stress and anxiety, helps maintain a healthy weight, improves sleep, and also helps with symptoms such as MS-related fatigue. So there are Canadian physical activity guidelines for adults with MS. They're being updated, I believe. But the initial version suggested 30 minutes of moderate intensity aerobic activity, so that's activity that gets your heart rate up, twice a week, as well as strength training, at least twice a week. And there are lots of ways that you can achieve that activity, and I think it's important to recognize there are ways to achieve this activity even if you're not able to do some of the things that are on this list. So walking, for instance, some people can't do, but upper body exercises like arm cycling can still allow people to get an aerobic workout. And you can still do strength training with resistance bands and so on. So that's something that you can ask for referral to a physiotherapist or a trainer who can help you work out a program that will work for you. So in summary, what we've talked about is some of the major factors related to disease progression in our current thinking in MS. So brain reserve, biological aging, the injury that occurs in the brain due to MS, and our compensatory resources, which are affected by age. These factors are affected by many other things. We've talked about some of them, your comorbid conditions, your diet, your physical activity, your social determinants of health. So at the end of all that, the important thing is, what can you do about it? Well, be as active as you can. Quit smoking if you're ready and able to. Focus on a brain healthy diet and aim for a healthy weight. Start disease-modifying therapy early if that's appropriate after discussion with your healthcare team. Get vaccinations to prevent infections. Treat or prevent your chronic health conditions. And try and work on that software, so cognitive leisure activities. And so that's where I would like to end, and I'd be happy to take questions.
Okay, Dr. Mary, thank you very much for this presentation. I do have one question off the top, and it has to do with a comorbidity, for example, concussion. A lot of kids play sports in their earlier years, or like myself, just accident prone and had a couple of concussions before I was 20. So how does concussion relate to MS, or is there any data on that?
Well, in terms of the risk of MS, there have been a couple of more recent studies that suggest that brain injury may increase the risk of MS. We still need to do some more work to try and understand if that's really the case and whether there's a way to mitigate that. When we think about once people have MS and we think about brain health, we do have some extreme examples in the general population that aren't MS specific, but when you think about the boxers, the football players, all the people who get repeated injuries, and we know that that is not good for the brain, right? So those really accelerate degeneration and damage in the brain. So I think it would be fair to say, although we haven't specifically looked at that in people with MS, that those types of injuries are likely to occur in somebody who gets repeated severe head injuries. And so adding that on top of what's already going on in the brain due to MS is likely to, add on to that injury. What we don't know is whether, because I think we can all identify times when we have walked into walls, we've fallen on the ice, hit our heads, and those kinds of things, how many of those and how severe do they have to be before we worry that that's going to make enough of a change that it would actually affect how we feel and function in day-to-day life.
Thank you. We have a question from a Zoom watcher. In my observation, treatment to brain health issues such as fuzzy thinking, declining brain plasticity, and diminished recall are limited. What are the barriers that would prevent healthcare professionals who specialize in the treatment of MS from addressing brain health issues?
Well, I think you've raised a couple of issues. So I think the issue with thinking about cognition is not addressing, I think is not so much addressing brain health as what tools we have. So the things like managing other health conditions can be helpful. So making sure somebody's diabetes are controlled, working on the things like the physical activity affecting mental health. But we haven't got a lot of tools that are highly effective about actually improving somebody's thinking and memory. Now, we do now have a couple of things. So there have been some recent studies suggesting there are some cognitive rehabilitation strategies that people can follow, but we still really need to develop some better strategies to do that. And so your average person doesn't actually have that tool to say, I can make cognition better. So it's really about more managing these other things and hoping that that will help. And we don't have any medications that really directly help cognition, although people have done studies to test, for instance, the medications you hear about used for Alzheimer's dementia. Those therapies have not been shown to be helpful in MS. So some of it is the things we've tried so far haven't been effective. It's very clear that this is an important thing to address. And so there are people working on it. It's just turning out that we just haven't gotten through the door of being really successful at finding an effective solution yet.
Okay. Related to this, what type of exercises or games might help boost brain health, specifically memory, information processing speed, and fluency?
So I can't necessarily.
Okay, go ahead. Sorry.
Yeah, I don't know if I can tie a specific exercise to a particular, like the cognitive domains that you specified. But I think what we can say is that it's trying new activities that make your brain work in new ways. And so it can be anything from learning a new language, whether you decide to do that with Duolingo or some other tool or a group. It can be learning a new game. It can be learning how to play music or taking up music again. Social connections, so interacting with other people. These are all things that are really important. The key is that you are making your brain try something new. So you're setting down new pathways, and once you try that new thing and do it for a while, that you don't just say, well, I've done my new thing. Like your brain needs to continue to be challenged and to continue to need to lay down those new pathways. It's also really important to deal with if you start having problems with your vision or your hearing, to deal with that, because the brain doesn't do very well if it can't see or hear well, because those pathways don't get used as much as they should, and then they tend to break down. So it's really about whatever you could do to actively exercise, in other words, work your brain.
Okay, one of the things that I do specifically, I vary my routes for my cycling, for my rides. So I'm not doing the same ride every day or the same trail. If I'm listening to music, I change up the music, I shuffle it so I'm not hearing the same song after the same song after the same song. So I don't know what's coming up, I don't expect it, so it's something a little bit new. Or I might change and listen to a podcast or a radio station as opposed to a playlist of songs. So I try to do those little things to make it a little more novel for my brain when I'm doing the same thing, which is riding my bike.
Yeah, so varying those things is helpful. Also trying to do things that make you do some learning, right? So trying to actually make yourself learn something and remember it can be helpful, even if it's not an enormous thing. Those kinds of things can be, very useful. Learning something new, trying to teach it to someone else makes you work your brain even harder. And so those are all strategies that can help improve that software part of our reserve.
Okay, on to our next question. What are your thoughts on Dr. Terry Wall's protocol diet? I hear more and more of the link between gut health and the brain.
Well, I can't comment really very explicitly on her specific protocol. I don't have the details in front of me. I think what we can say is that we know diet is very important for health. And the gut microbiome, so we all have bacteria, right? It's on our skin, it's in our mouth, it's in our gut. And the gut has a very large immune system. It's actually, therefore, has some very, what we eat and the bacteria in our gut do have an important influence on immune health. And we know that there's also what we call the gut-brain axis, so an influence between that and the brain. And so it is clear that the kinds of things that you eat do influence both immune as well as brain health. In general, I'm going to say, without getting at a specific person's diet or related protocol, diets that have us focus more on the, fruits, vegetables, grains, getting away from, some of the, heavily kind of processed things, the things that are high in salt and those things, people tend to do better with. It's all part of, again, I think most things can be dealt with in moderation. So it's up to the individual, if you are following a specific diet, really to discuss it with your healthcare provider and make sure that then if you're making those changes, that there isn't anything else you're missing. So we know if you follow a vegetarian diet, it's actually in general, fairly healthy diet, but then there's some additional choices you have to make sure that you're not missing some of the vitamins you might get from some of the food sources that you leave out of your diet. So whatever diet you're choosing, it's really trying to figure out what are your outcomes that you're trying to achieve, and are you making sure you get all those core nutrients that all human bodies require to maintain health.
Am I mistaken in feeling that there's been a more holistic approach, say, the past 20 years in dealing with MS? I know during my early diagnosis, people were saying, oh, you have to do this, this, and this. And now it's more, let's look at all these different factors and combine them.
So I think that's a fair observation in the sense that we've developed a much better understanding of the scope of things that affect the brain and the immune system. And so as we learn more about the factors that play a role, so some of the things that I've talked to you about today, the more each piece that we begin to learn has a role, we then need to bring that into that overall management plan. And so at the same time as we've had more options from a medication standpoint to deal with relapses, for instance, we've also acquired all this additional information about all of these other factors about health behaviors and other existing conditions and life circumstances that play a role. And so we really need to bring those together. And I expect you're going to find that 10 more years from now, there'll be even more things on the list because we will have learned more about those factors. And maybe that framework that I've talked to you about will need some additional updates because we have learned more.
Thank you. Is there any evidence that people with MS have lessened cognitive abilities even before diagnosis compared to the general population, or are all effects of MS observed only as the disease progresses?
So that's a trickier question than you might imagine because there's an important question about when MS begins. So historically, we would sort of say, well, MS begins when you have your first symptom. So if you had the acute visual loss from optic neuritis or your first attack where you get numbness from the waist down. But one of the things that we have learned in the last few years is that MS, at least from a under the surface perspective, from the changes in the brain and the immune system, likely begins years before people's first symptoms of MS present that they're aware of. And so when we started looking, there have been a few studies that have looked at cognitive performance in people during the period that we think of as what we call a prodrome. So some of you may be aware of the prodrome. Think of it as a warning phase. If you know people with migraine, some of them will say, oh, I'm going to get a migraine because I'm feeling irritable, thirsty, extra tired, whatever their kind of warning is, and they may get it a few hours or a day ahead. So in MS, we think that that's likely years, maybe 6 to 10, possibly longer. And so when we've looked in that time period, we see that people with MS are already showing changes in cognition, even though they didn't yet know that they had MS. So we haven't been able to get back to a point yet where we could look where we're fully confident that the disease process hasn't started. So I can't really answer that question. What I can tell you, though, is there have been some recent studies looking at genes in MS that suggest that there are some genetic differences, perhaps in some of the cell types in the brain. And so maybe there's some fundamental difference in some of that brain structure that we were talking about earlier in people with MS before the disease starts, that maybe makes them more susceptible to MS. And that's something we're still working out. But I think we can say is that cognitive changes in MS occur at the earliest point when the disease begins, even if we don't yet know the disease has started.
Okay, I'm excited to learn more about the future of genetics and MS and the role that genetics plays in MS. And I guess that's something I'm going to have to wait for. We have a couple of questions that are a little bit off topic, but are of interest to some of our watchers here. Are people with MS who are on a DMT more at risk for measles, even if they were vaccinated as a child?
So, well, if we start with it, there are a couple pieces to that question. So first, if you were vaccinated as a child, you likely are still immune, provided you got 2 doses. So we know most people who got 2 doses are still immune. If you're on one of the therapies that does not suppress your immune system, it should not affect your risk. And as long as you were vaccinated as a child, even if you're on an immunosuppressive therapy, you likely have retained your ability to fight off measles. Now, there's a very tiny proportion of the population who, even if they get vaccinated, don't really mount an adequate vaccine response. And so for those individuals, they would be at increased risk, but that's not so much a function of their disease-modifying therapy. It's a question, it's certainly reasonable to ask your healthcare provider if you haven't been vaccinated, keeping in mind that if you're on a therapy that suppresses your immune system, that you can't get vaccinated. If you're not on one of the immunosuppressive therapies, then that's still potentially available. So that's something that should be reviewed. And I would say a significant number of clinics, although perhaps not all of them yet, will look at whether people have been vaccinated for those childhood illnesses before putting people on therapy, because it's harder to deal with it later on.
Okay, and kind of related, does having Lyme disease in the past increase the risk of getting MS?
I'm not aware that there's been any study that has specifically addressed that question. That may come up in the future as Lyme becomes endemic in more and more parts of Canada and more people are going to have had that history of exposure, but I'm not aware that anybody has actually looked at that question.
Okay, that would be interesting because I just got bit by a tick 2 nights ago. I'm not impressed.
Yeah.
Regarding biological versus chronological age, do neurologists calculate that to assist with individualized treatment plans?
So good question. So we don't yet have an easy way to calculate that. So it's not something where I can just ask you a whole bunch of questions and get an accurate measure. There are some blood tests that are not available to us for clinical use at this time that allow us to do measurements. I'm hopeful, though, if we can get a better handle on the value of biological aging and whether that should inform our treatment decisions, that we can then make a case to get access to those things. But usually we have to actually show that the test that we want is going to be useful in practice and how before we can get access to it. Right now, it's a fairly expensive test that I couldn't order no matter how long I begged for it.
Okay. And we've got time for one more question here. Would hormone replacement therapy for women experiencing menopause and have MS help with their brain health, protect some decreased cognitive decline? Exercising your brain / learning, can that include watching videos or using virtual reality goggles or a system?
Okay, well, why don't I start with the hormone replacement therapy question? So this is actually a question of great interest to the field, because that graph I showed at the beginning, just shows you just how many people are in the age range where menopause is going to be a consideration for them, right? And going through menopause-related symptoms, not that fun for many people, so this question comes up a lot. So we don't have a firm answer to that question yet. So there are some data in animal models to suggest that there might be some benefits to brain health for women with MS, and we know that there are several studies, although they don't all agree, that suggests once people go through menopause that the rate at which they worsen if they have disability gets faster post-menopause. Now, not all the studies agree with that, which is why we need to do some additional work. And so one of the interests now, so there's actually the National MS Society, so a sister organization to MS Canada in the US, has actually got a call for applications specifically to ask people to address some of these questions around women's health in MS, to clarify, questions about, is hormone replacement therapy equally safe in women with MS, given that they have different risks of comorbid health conditions? Is it effective in dealing with those symptoms? Would it be more helpful for people who already have significant problems with fatigue and brain fog and some of the other things that come up? And then the overall things like the effects on brain volume. So these are things for which we only kind of have preliminary and inconsistent answers. But I expect there's going to be a dramatic increase in the amount of attention that this gets over the next 5 years. So hopefully we'll be able to answer that in a really firm way in the near future.
Okay, well, we've come to the end of our time for questions. Dr. Mary, thank you so very, very much. Fascinating subject, and I learned a lot. I hope everybody else did. And as we wrap up today's broadcast, we do want to remind everybody how you can connect with the MS Knowledge Network, which is staffed by trained navigators who provide consistent, quality information and support. You can connect by phone, by email, or live chat through the MS Canada website. Navigators are available Monday to Friday from 8 a.m. to 8 p.m. Eastern Time and can provide assistance in both English and in French. We want you to be part of the MS community and encourage you to get involved with our programs, services, events, government relations, and volunteer opportunities. Together, we can take action to create a future free of MS. To find out how you can take action, check out our website at mscanada.ca. If you have questions about any of our education activities, you can reach out to the education team by email to education@mscanada.ca. On behalf of MS Canada, thank you for tuning in for today's webinar. Good night.